much. So, today I will share about the AUSS technique and little. I think the AUSS technique maybe professors will first to hear. I'm the inventor of the AUSS technique. My name is Sun from the first affiliated hospital of Kunming Medical University. And today I will share the AUSS UNSES technical concepts and operational principles. And for the AUSS technique, means arthroscopic assisted uniportal spinal surgery, briefly AUSS. And another name is uniportal non-coaxial spinal endoscopic surgery, UNSES. And the AUSS technique was first proposed and clinically applied in China in 2021, September the 7th. And the AUSS technique has working and observation channels. The two are located in the same incision. We use one hand to hold endoscope, and while the other hand to manipulate surgical instruments, and each can rotate and swing freely, like we use the chopstick, so I call it chopsticks technique. And the advantages of AUSS technique, the AUSS technique is simple and quick location the surgical segment with minimal exposure to fluoroscopy. And I usually use the 30-degree arthroscope. And the arthroscope provides a wide field of view with 360-degree freedom of rotation, reducing blood spot during operation. And the AUSS technique has no fixed channel limitations, and the AUSS technique can perform the surgery on 2 to 3 spinal segments through a 1.0 to 2.0 centimeter incision. And the technical features of AUSS. The AUSS technique integrates arthroscopic triangular operation, like we use the arthroscopic surgery in sports medicine. Also, the UBE technique is all the triangle operation technique. Also, with coaxial spinal endoscopic coaxial translation and swelling technique, like we use the PTDPLD, the uniportal spinal surgery. So we also develop a unique non-coaxial rotation technique. So the arthroscope and the operation tools can be swing freely and rotate from each other, and further enhancing the operational space and enhancing flexibility. So this is the indications and key technology of the AUSS technique, include different kinds of disc herniation, like the bilateral calcified upper abdomen aggregated and from cervical, thoracic, and lumbar spine, and also the spinal stenosis of the cervical, thoracic, and lumbar spine, also cervical radiculopathy, cervical spondylotic myelopathy, ossification of the thoracic ligament flavor, lumbar spondylolisthesis, ASD, intraspinal lesion resection, like different kinds of cysts, neurofibroma, schwannoma meningioma, or bone cement leakage resection, and also assist the thoracic lumbar bursa fracture reduction, Ford syndrome, complex regional pain syndrome, or cervical ossification of the posterior longitudinal ligament, or infection like the tuberculosis. And key technology of the AUSS technique include annual repair technique, dual cycle repair technique, ligament flavor sparing suspension technique, single incision multi-level spine surgery, modified circle joining or BD technique, and also assist ACDF, ACCF, ACAF surgery or modified PT leaf. So this is the approaches of the AUSS technique. Literally, I will introduce to you. And anesthesia and patient positioning and include we usually use the prone position, and the AUSS technique can perform under general anesthesia, combined spinal epidural anesthesia, or local anesthesia. And we can see here is from the B AUSS biomedical company the equipment of the disposable steroid waterproof surgical drap. We can use it like the demonstration. And the first is a surgical approach. For ipsilateral lumbar lesions, we can use the one incision, the vertical incision of 1 to 2 centimeter, and medial pedicle line parallel to the spinous process median line. And very important is the lateral view, and it's target to the intervertebral disc space, and the indications like different kinds of disc herniation resection or remove of the different kinds of cysts in the ipsilateral side. And for the laminotomy, we call it the under the AUSS technique, we call it circle joining technique. And the anatomical landmark for the laminotomy is circle joining technique. The starting points for laminotomy is the spinous laminar junction, and we draw the circle. Partial removal of the superior lamina and partial removal of the inferior articular process of the superior vertebra to expose the SAP of the inferior vertebra. And then we can see the joint space and the articular process. And then to draw a circle, continue to draw a circle to the partial remove the inferior lamina for the ipsilateral laminotomy. And the key technology is one of the key technology of the AUSS technique is ligament flavum sparing suspension technique. After we do the laminotomy, we can releasing of the ligament flavum at its severely caudal facet joint attachment point. The ligament flavum was stripped using nerve dissector curette to create a free petal-like structure with upper, lower, and lateral edges. And then the fat side of the ligament flavum was sutured with 4.0 sickle thread without knotting, and the double thread was ejected from the body, and a consistent traction force was maintained throughout the procedure to elevate the ligament flavum for intraspinal surgery, resembling the acting of the unveiling curtain or the ligament flavum suspension technique. And after surgery, the suture were removed and the edge of ligament flavum was trimmed and recovered the ligament flavum, and which helps reduce the postoperative intraspinal lesion. And for my cases, a lot of the revision surgery, and if we can enter the full endoscope, if I can see the clear line of the facet joint, the bone and the ligament flavum is very important. So for the younger patient of the lumbar disc herniation patients, we did this technique for more than 4 years, and ligament flavum suspension, sparing suspension technique combined with annular repair technique. So this is a demography of the sparing suspension technique. You can see after surgery, we recover the ligament flavum. And also the traction force, we usually use the forceps, just one or two hemostasis forceps is okay. So we can see from the left of the photo, we can see one incision. We hold the endoscope, oscilloscope, and also radio frequency ablation. Also, we use a key wire. We can see the key wire just for the nerve retractor, and then the thread use the hemostasis forceps, and one incision we can do this about hold four things. And for the video after surgery, okay, lift up the ligament flavum, can see the fully decompression of the transverse nerve root. Also, we can see this is 40 stop thread needle for the one stage of the suture of the annular repair. Okay, annular repair, and then recover of the ligament flavum. Okay, so multiple suture annular repair technique. So for irregular and large tears in the annular fibrosis, increase the difficulty of suturing and lead to the high failure rate of suturing. And we all know, but in China, we have more than 80 years of experience to do the annual repair technique. Also, the BL Spine equipment company also have the annual repair device. And I usually use the annual repair device also combined with 40 stop thread needle for the annual repair. Okay, for this is for the patient double suture annual repair technique. Depending on the size of the annular fibrosis rupture, we can do the parallel double needle suture, cross-shaped double needle suture, or X-shaped double needle suture. And we can use the annual repair device. Also, we can use the annual repair device combined with 40 stop thread needle. And this is a Palisade fast-shaped triple needle suture annual repair. You can see the big defect the big defect on the annulus fibrosis. First, we did the two double needle suture, use the 40 or subthread needle, parallel double needle suture, and from the cephalic side to the caudal side. And then from the middle to the facet joint direction, we use the annual repair device. So we can see it can close the defect of the fissure on it of the annulus fibrosis, perfect to close its strength and tight. And for another is the apodermic irrigated lambda herniation. After removal of the protruding nuclear pulsars, we can see the rupture or the fissure or the defect in the annular attachment area at the vertebral body edge. So we use one hole drilled with two 2 millimeter key wire on the vertebral body, positioned 2 or 3 millimeter from the edge of the ruptured area, and one suture needle was then inserted into the vertebral body through the hole, and the thread rod was pushed in, and the suture needle was pushed out, and it's in the vertebral body. And another suture needle with suture loop pierce another side of the annulus tear into the annulus fibrosis, also at a distance 2 to 3 millimeter from the edge of the ruptured area. And the suture needle was then put out and knocked slit in and locked automatically. We can see the suture needle had a loop. The tumor knots were tight and the knot pusher was used from outside to inside. The suture was cut by a suture cutter. And for the first stage, and we usually to do double needle suture, we can close the inspiration of the annular repair of the rotator cuff. We call it footprint concept. We use this concept to the annular repair technique of the rupture on the vertebral margin of the vertebral body of the annulus fibrosis. So we call it bone anchored. For this case, we did the bone anchored X-shaped double needle suture. Okay, and for this patient, we can do the triangular double needle suture, X-shaped double needle suture, or parallel double needle suture. Okay, for the spinal stenosis, it's ULBD circle joining technique. And for the approach, also the vertical incision of 1 to 2 centimeter and a line connecting the middle points of the pedicle, the middle pedicle line, and parallel to the spinous process midline. Also, from the lateral view, it target to the intervertebral disc space. Okay, this is circle joining technique. And the starting point is from the base of the spinous process. We're using high-speed drill. And high-speed drill, I usually use the high-speed drill of the 4 millimeter diamond tip to remove the upper and lower edge of the lamina bone and exposing the starting and ending points of the ligament flavum, so we can see the natural cleft of the ligament flavum. And bilateral partial laminectomy and medial fascectomy expose the tip of the SAP of the facet joint and the joint space is the key landing mark. And then remove of the ligament flavum. The ligament flavum was removed to decompression the central spinal canal. And for the UB technique, I did UB technique in 2021 and did more than 500 UB cases in 2021, and then I do the AUSS technique for 5 years. Okay, for this year's of UB technique for the ULBD in China, we called it en bloc technique, so entire resection of the ligament flavor. But the detachment of ligament flavum with the help of cuirass and the crescent punch, followed by flavectomy piece by piece removal using the crescent punch, is safer and precise than total en bloc flavectomy. So my experience is starting point of the natural cleft and use the radio frequency ablation, the small radio frequency ablation for detachment of the adhesion part, piece by piece to remove. Because in China we have lots of older patients, elderly patients. For these patients, they did a lot of conservative treatment, all the intraspinal injection of different kinds of drugs. So these patients have a lot of the adhesion or scar tissue. So if we have the en bloc, maybe to cause the dural tear. So piece by piece, it's much safer. And then after the decompression, we can see the central spinal canal decompression and also bilateral nerve root canal entrance and lateral recess and the disc space and also fully decompression. Okay, let's see the case. 69-year-old female, L45 bilateral lumbar disc herniation with calcification. And also this patient combined with spinal stenosis. This is 2020, the 4 years ago case. Okay. The first we did the ULBD sacral joining technique for the central spinal canal decompression and also exposure of the both side disc space and lateral recess. And from this photo is from the contralateral side discectomy. Because of the calcification, we use the 2 mm key wire as the nerve retractor. Then we use different angle of osteotomy, bone chisel, or the different the 1 or 2 mm 160-degree crescent punch for resect of the herniated disc. And this is for the ipsilateral side discectomy. Also use different angle of bone chisel and different size of bone chisel, scalpel, the knife. Also the pituitary forceps and crescent punch. And after the surgery, we can see the preoperative CT scan, the postoperative CT scan, and total resection of the herniated disc, and also uh, fully decompression of the central spinal canal. And very important thing is the facet joint preservation is good. Okay, this is contralateral side. Okay, this is the L5 root of contralateral side. Okay, central spinal canal. Okay, for the decompression. And didn't cause the instability. Okay, here is the ipsilateral side. Okay, for this case, 70-year-old male, L23 ossification of the ligament flame causes the spinal stenosis, severe stenosis. And we also use the circle joining URBD technique. For this case, very important is we must detect the if there is a dural ossification, okay, fully decompression. And after surgery, we can see fully decompression of the central spinal canal and a good preservation of the facet joint. And this is the advantage of the AUSS technique for one incision multi-level spinal surgery. And this is the approach of the one incision by segmental surgery and the two methods to location. And think the most quick one is the second one. Intraoperative AP view, we can say identify the midline connecting the pedicles and mark the skin projection point of the central bisection line through the middle vertebra, like the L34 or L45, the middle one in the L4 vertebra, and the bisecting line through the L4 pedicle and project to the skin. And this is the central at this point to make the 1 or 2 centimeter incision. Okay, we can did the one incision by segmental surgery about the discectomy and annual repair, also the ULBD decompression of the spinal stenosis. Like this case is L34 and L45 spinal stenosis. From the axial view of the MRI and the CT scan, we can see the severe spinal stenosis, hypertrophy of the ligament flavum, also the hypertrophy of the facet joint. And this is L34 for use the so-called joint ULBD technique for the central spinal canal and the bilateral transverse nerve decompression. Okay, this is L45, also central spinal canal, also the bilateral transverse nerve root decompression. And this is one incision. We can see the video. This is L45 level. We can see the central spinal canal and bilateral transverse nerve root fully decompression. And very important things to use one incision to segmental decompression is the middle vertebral the laminar preservation. We didn't do the hemianectomy. Here we can see we preservation of the L4 lamina. Okay, this is L34 level. We can see central spinal canal, bilateral exposed bilateral disc space, also the bilateral transverse nerve root. Okay, here is the lamina, preservation of the lamina, not to do the laminectomy and hemianectomy. Okay, after surgery, we can see fully decompression and also the facet joint preservation, very, very important thing. Okay, we did more. By myself, I did more than 200 of this case one incision by segmental ULBD technique decompression. And interval diffusion technique. Today, Professor Li Dapeng will introduce about the fusion surgery. Okay, let's did it quickly. Okay, and this is also vertical incision of 1 to 2 centimeter, the lateral pedicle line, and the lateral to the lateral pedicle line for the 5 millimeter or 1 centimeter, and parallel to spinous process midline intraoperative lateral view also target into vertebral disc space. The indications of the PT leaf surgery or URBD PT leaf surgery. So this case alpha 5 instability causes lumbar spinal stenosis bilateral symptom. Okay, first we did the URBD technique, and for fully decompression, and then we can see the vasectomy to exposure of the uh, Hamming triangle, and then use a knife and also the instruments to discectomy, also prepare of the end plate. Go on the scope, you can see. And I about 4 years ago, 5 years ago, 4 or 5 years ago, I did UBE PT leaf. And compared to the UBE PT leaf or multiple unipotal, and I think the OSS technique also have the advantages. The first, we can use one incision. Is the whole procedure like the MST leaf in the water media medium. So you can enter to resect of the entire IAP, inferior articular percent, not piece by piece. And then the direction is towards the intervertebral disc space, and then you can use this direction to fully decompression, also to prepare the end plate very easily, and then insert the cage also very easy for the right direction, not cause to damage of the end plate. Okay, after surgery, we can see the fully decompression of central spinal canal. Okay, contralateral side, and for the ipsilateral side, we can see the cage, also the L5 traversing nerve root. I think this is very easy for the fusion surgery because it's also the same procedure like the MST leaf. And then it's very, and the advantage is, I think is the has advantage better than the MST leaf is for the contralateral side decompression. Use the water medium. It's more clear and fully decompression. Okay. For this case is the L4 spondylolisthesis, also combined with upmigrated disc herniation. And we can see the upmigrated herniated disc. And for this case, this patient have the four nerve root symptom. So it's L45 because L4 and L5, both sides have the symptom. So for this patient, we do the full nerve root decompression. And for the both sides, traversing nerve root and exiting nerve decompression. And when did the surgery, we can see the herniated disc is the end plate. Okay, remove of the end plate, also the full nerve decompression, then the fascectomy, the cambium triangle, expose the cambium triangle to the discectomy, and also the annular and end plate uh, preparation, bone graft, insert the cage. We have first is freedom, and we also have enough space, and then the percutaneous pectoral screwings and the rolled fixation. And for the ischemic spondylolisthesis, as this patient L5, and we also to do the full nerve root decompression. And if we meet of the adhesion, and we can use different kinds of basket forceps we design to insert piece by piece resection. And for this case, we can see the full nerve root decompression and the fusion. For the fusion surgery, I think it's simple. We can do the same procedure of the MST leaf, and also have the advantage to do the contralateral side decompression. Okay, AUSS technique consists the percutaneous pedicle screw placement, the direct visualization of the automatic landmarks with the endoscope, and the isthmus, the bars in the articularies, medullary process, lateral bundle of the SAP, and transverse process, and the design entry point was selected, and the superior cortex of the entry point was opening with a burr, and the pedicle tract was created using cannulated pedicle needle. Okay. In China, right now in China, more than 400 hospitals adopted to use the AUSS technique. And we have lots of experts in China to do the AUSS technique. Today, I will introduce, and this is Professor Liu Yun's case, the AUSS-assisted CM approach for leg screw fixation and bone grafting in L5 ischemic spondylolisthesis. For this patient, we can see it's not the slippage of the L5, so we can see the defect of the bilateral isthmus. And use two incision. One incision use CM approach to see the defect of the isthmus and do the debridement, and another and bone graft. Another incision lower is to insert of the key wear and lag screw. So two incision, bilateral lag screw fixation, and bone graft. And for Professor Gogodon's case, it's all TLIF with olive cage use unilateral Welter's approach, and one incision for the decompression of the spinal canal, and also to do the TLIF surgery and the horizontal of the big cage of the one incision. About the professor goal to have the research of more than 30 patients for do this technique, and after 1 year follow-up, no one have the complications of the fusion surgery like the subsidence or the instrument failure like the screw cracked, and for and also have the good fusion have a good fusion results. And this is for the Professor O's case. And to the tuberculosis also assists the posterior lateral approach debridement of lumbospinal tuberculosis focus, spinal canal decompression in the body, bone grafting fusion, and pedicle screw fixation. And for some case, for my case, and some case of the tuberculosis, just for the decompression is okay, and also the resect of the tuberculoma and also bone graft. And this is Professor Zhang case. Today, Professor Zhang will show his case lately. And this is also six olive surgery. And later, Professor Zhang will have the details to you. And another approach is the flat lateral approach of the AUSS technique. About 5 years ago, I designed of the flat lateral approach, and 5 years ago I designed the astroforaminal approach. 2 years ago I designed the transforaminal approach. Okay, for astroforaminal approach, it's vertical incision of the 1 to 2 centimeter, 3 centimeter lateral to the target foramen isthmus. On the lateral view, the incision opposite the intervertebral space. Indications include far lateral disc herniation, foraminal stenosis, Ford syndrome, Bartholdi syndrome, and also TLIF surgery. And quick location and above the L5S1, like the L34, L45, L23. A longitudinal incision is made along the line connecting tips of the transverse process of the adjacent vertebral body, also originated laterally towards the foramen region. Like the L34 or L45, the quick location is the tip of the transverse process and connecting the line and the vertical incision. Okay, the first docking point is the isthmus. It's very safe. And for L5S1, I think it is complicated. So because of the L5 transverse process, sacroiliac iliac crest. So the incision according to the position of the iliac crest is 0.5 to 3 centimeter lateral to target foramen or isthmus. Depending on the location of the lesion on the left or right side, the bony structures to be removed varies. The incision can be extended cranially or for large space for operation. So because of the three anatomical landmarks, we design the incision individually. Okay, like this patient. Okay, we must design according to the preoperative imaging. Okay, for the transverse process approach, like we did the PLDPTD surgery, the uniportal for endoscopic surgery, and the incision is located 6 to 10 centimeter lateral to midline, and also towards the lateral view towards the foramen region. The indication why we use to design this transforaminal approach because a case I did the L2 L23, the case of the spinal stenosis. I did the ULBD surgery And about 1 year later, the patient had the central herniated disc, lumbar disc herniation. I used the posterior approach. I caused the dural tear. So if we use the transforaminal approach, didn't to remove much of the facet joint and the isthmus, we can enter to the use the PLD surgery. We can to direct to decompression of the herniated disc. So after this case, I did the transforaminal approach. Okay. The indication is high-level lumbar disc herniation, foraminal stenosis, foraminal disc herniation, large central disc herniation, with a risk of dural tear in the posterior approach surgery, including revision surgery is my case, and and also TLIF surgery. Okay, this is the demography, the photo we can see, like the unipostal PLD surgery. Okay. Also, we did, it's also my experience. I also called it circle tactic. The anatomical landmarks is transverse process of the superior vertebra, isthmus of the superior vertebra, and the transverse process of the inferior vertebra. The tip of the superior articular process of the inferior vertebra, and after remove of the isthmus about 5 millimeter, we can see the SAP of the inferior vertebra and also joint space and also the articular cartilage. And when we did the discectomy surgery and fully decompression of the existing nerve, we can see it's like draw the circle. Okay, the procedures of the bilateral approach, we can see first expose the isthmus, we can use the radiofrequency ablation and use high-speed drill to remove partial of the isthmus and the explorer of the SAP of the inferior vertebra. And we also can see the articular process and then to use crescent punch to remove of the ligament flavor. And under the ligament flavum is not the herniated disc or the exiting nerve root. And it's the fat tissue and the vascular network. So the possible source of bleeding comes from the complex plexus of the veins and adhesion around the neurovascular structures. So we use the small radiofrequency ablation to pre-hemostasis and then find to pre-hemostasis stop the bleeding and to expose of the exiting nerve root and the herniated disc. Then remove the herniated nuclear pulsar tissue decompression and release the exiting nerve root. So the range of exiting nerve root decompression from cranial, caudal, dorsal, and ventral part. 360-degree decompression of the exiting nerve root. And also my experience, a lot of hospitals ask me to do the surgery, to do the revision surgery of the bilateral disc herniation. So for this case of L5S1 or combined with Bartholdi syndrome, like the hypertrophy of the L5 transverse process and L5 transverse process fusion with the sacroiliac, and we must remove partial of sacroiliac. This is very important. And I think we are the first to do the bilateral discectomy and annual repair. We also read the book and published the book. And about 3 years, we did more than 100 of this case to the annual repair of the bilateral disc herniation discectomy. Like we can do the single suture or double needle suture, triangular double needle suture, parallel double needle suture. And then to remove of the schwannoma resection, for this case, we can see the L12 foraminal schwannoma resection. Use the bilateral approach. And also preservation of the facet joint, not to do the fusion surgery. Okay, for difficult one, it's Bartholdi syndrome, fault syndrome, calcified disc herniation in the foraminal region. We can see for this case. So, this is serial online courses of the OS technique. My plan is have the 5 sessions. So today I just introduce of the briefly introduce of the OS technique. Maybe the next another 4 sessions is the annual repair, bilateral approach, and ULBD fusion surgery, or cervical thoracic, and also AUNES. So we also arranged for another sessions. So for the details, we have 1 session to introduce the bilateral approach. For the maybe next month, the second session, I will introduce to you. We have a lot of this case, difficult one. Okay. So let's summarize of the phalet approach. We have the large operating space for explore the lesions outside and inside the neuroforamen. And one incision can be used to remove the bilateral disc herniation in 2 segments and also perform decompression in the neuroforamen area. And also bilateral disc herniation discectomy with annual repair technique. We we also have the single session to introduce I will introduce the bilateral approach. And then for the cervical spine, we can do the cervical radiculopathy, nerve root canal stenosis, disc herniation, discectomy, and the decompression, and single incision by segmental surgery. I think we didn't not what I didn't call it keyhole. We have I think this is the laminotomy combined with nerve root canal decompression. We have much larger decompression space. So also when we do the one incision by segment surgery, we didn't do the laminectomy, hemilectomy. So we also preservation of the 3 or 4 or 5 millimeter lamina. Okay, cervical spondylotic myelopathy or ASD, and this is circle joining URBD technique for central spinal canal decompression. I also use the URBD technique, circle joining URBD technique. So like the patients, after the patient have the 3 level ACDF surgery for the C3, 4, this level have the spinal stenosis. So we just one incision, 3 level decompression of the spinal canal, just one incision. Okay, after surgery, fully decompression. And also assist ACDF and ACCF surgery, I think is also very easy to do this. Because we can see clearly of the spinal cord, we can see clearly of the bilateral, the nerve root starting point. So this point we use a microscope, we use open surgery, we use a loop. I think it's also have bleeding, a lot of bleeding here. But under the OSS technique, we can see the starting point of the nerve root, and we can stop the bleeding, pre-hemostasis, and see it clearly. Also, annual repair technique for this one is C6 and 7 annual discectomy of the herniated disc, and then we can see a defect of the annular fibrosis. Then we use the annual repair device. We also use the ligament flavum suspension technique. And but I didn't suggestion for the annual repair of for the different level because we all know the paralysis of the L5. So for this case, we have enough space to do this, but not to have the force to retract of the nerve root. Very dangerous. And for this case, is after ACACF surgery, the patient have the complex regional pain syndrome. So the first we designed from the C67 to the entry point to insert the spinal cord stimulation surgical electrodes placement, and from C6 to C3, And we designed this so the starting point is C6 and 7 and use the ULBD circle joining technique to fully explore of the spinal cord, then insert the surgical pedicle electrodes. Okay, this case is from Professor Li Jinsong. And for this is the posterior C1, C2 instrumentation combined with posterior artery section and also assisted removal of the retroodontoid lesion via the surface of the facet joint corridor. And for OSS technique, we do a lot of surgery of the C0 and C1, C2. For this case, it's the intraspinal lesion resection from posterior approach and use OSS technique to from the posterior approach to resect of the ventral odontoid lesion. Very difficult one and very dangerous. Okay, for this case is C1, C2 materialized cage implant in China. The OSS team, the experts from the OSS team, they did the upper cervical spine about more than 50 cases of different disease. For this is the cage insertion, and the directly under the OSS technique, we can see the facet joint and the resect of the articular cartilage, and then insert of the cage of C1, C2 from the Professor Liu Yun's case. And also this is from the Professor Yan Yiguo's case, and 60-year-old male and chronic odontoid process fracture, and use this is not cage, just the autograft, the bone graft, auto bone graft for C1, C2 fusion. And Professor Yan Yiguo's experience is first to do Atlas pedicle screw placement for endoscopic, and then to order atlantoaxial lateral mass joint fusion, also remove the hernia, the articular cartilage, and the auto bone graft, and then insert the axis pedicle screw placement and rod placement. So it's very small space. So Professor Yan Yiguo also designed a new instrumentation of the screw and rod, a new design. Right now is he designed the screw and he designed of the tail of the screw and the rod for C1, C2 fusion for endoscopic. Okay, after 3 months, we can see for the left side have the fusion phenomenons, and we also can see just a 2 incision or 2.5 incision. We can do the survey. In China, we did a lot of this for the C0 to C1, C1, C2 surgery, also transoral. Also do this about the Professor Li Jinsong also do the transoral approach to the OSS technique of the C1, C2 odontoid resection. Okay, thoracic lumbar spine. Maybe the fifth session, and every month my plans every month we have the one session, and the final session I will introduce of the cervical and thoracic and AUNS technique, and I will introduce more details, more cases of the C1, C2. This uh, this disease of use OSS technique. For the thoracic spine, we can see the ossification of the thoracic ligament flavum resection. Use the ULBD technique, ULBD circle joining technique. I think it's very simple um, to the experts to do the endoscope for the thoracic spine. But very important thing is the dural ossification is very important. So we from the preoperative imaging, we must to have the detail and confirm where is the dural ossification part, and we use the floating technique. And for this case, it's T2 and 3 from the Zhang Jinli's case, T2 and 3 severe uh, ossification of the ligament flavum. And the key procedure include over-the-top decompression using layer by layer drilling technique and piece by piece removing technique and minimizing dural manipulation, all citing decompression method. Okay, for this case, we can see fully decompression. Okay, also resection of the intraspinal bone cement leakage at the T8. And also very difficult one is this ventral calcification resection. From that approach, this approach must to remove a large part of the facet joint. And we can see for this case, the first the dorsal point decompression, then the ventral part decompression. Very dangerous for this case. Okay, intraspinal lesion resection, like different kinds of cysts, like the lumbar disc cyst resection, like the perineal cyst, nervous sleeve cyst resection, like the gap containing lumbar disc cyst resection, like this, from Professor Liu Anguo's case, schwannoma resection from L2 level, intradural extramedullary tumor resection, inside of the dura, find the tumor, resect of the tumor, and then suture of the the sickle sac. And for this case from Paleobal's case, Professor Paleobal's case is also associated intraspinal meningioma resection at T6 and 7 level. Also, for this case, Professor Guggenheim's case, also meningioma resection at the T7 level. A lot of the intraspinal lesion resection of the AUSS technique. Also, right now we write a lot of paper of this. Okay, for this case from Professor Champeng's case, the AUSS combined with percutaneous pedicle screw fixation technique, treatment burst fracture combined with nerve root injury, and first you OBD and then find the fragment and use the L-shaped fracture reducer or restorer to reposition of the protruding fracture fragment and also combine a fixation of the pedicle screw. Okay, one incision, three segment surgery. For this is the I think is also another advantage. But for three segment surgery, always we did the cervical and the thoracic spine. Okay, this is my case about one is in a three segmental surgery of the UOBD, or the discectomy or the nerve root canal decompression. We also can use one incision, three level. Okay, CM approach. For CM approach is crossing midline approach, also we call it crossing spinous process approach. And the surgeon's position is standing on the contralateral side of patient. So the advantages is maximize preservation of the facet joints, avoids sparse interarticular fracture, and allows simultaneous exposure of both the existing and traversing nerve root. So the surgeon is standing on the contralateral side and near the adherent to the spinous process line to do the surgery. For this is the lumbar spine disease like the discectomy, especially the upper and down migrated lumbar disc herniation. Also can do the ligament flavum sparing suspension technique. Also can do the annual repair technique. And for the cervical and thoracic spine, it's also the contralateral side, standing on the contralateral side, and then cross the midline near the midline to do the contralateral side decompression. And for this case, we can see the nerve root for the cervical spine is L34 foraminal stenosis and cervical radiculopathy. And for the decompression, and for this case is fully to preservation of the lots of the facet joint. Okay. Also, Professor Liu's case, and this is also combined with thoracoscopic technique for the treatment of T10 and 11 incher and extraspinal neurofibroma. And large neurofibroma, for Professor Liu did more than 20 cases of the neurofibroma, the large neurofibroma, and used all technique to find the origination always in the thoracic spine and find the thoracic spine and cut of the tumor and then to use the thoracoscopic technique to resection of the tumor. Okay, just we use the two endoscopic technique to do this surgery. And AUNS technology is beyond the spine disease. We also designed a new technology derived from the AUSS technique. And I am in sports medicine department, so I did the joint surgery of the arthroscopy. So AUNS, arthroscopic cyst unipolar non-coaxial endoscopic surgery. So the first paper we published is to do the fibrous dysplasia of the femur and use the AUNS technique. And it can use one incision, have the non-coaxial technique, and provides clear surgical field precise lesion boundaries and curettage minimum blood loss. And then we can see this is the paper we use for the primary dysplasia of the femur. And for this paper, we publish is to do the recurrent osteomer resection of the femur neck of the 10-year-old patient. This is use the 3D print, also the navigation system, combined with AUNS technique for resection. The osteomer. And we also can use AUSS-assisted endoscopic reduction and elastic intramedullary nail fixation for pediatric comminuted femoral shaft fracture. Also, annual whole meniscus debridement and contouring, use one incision. And also to use the AUSS-assisted modified medial single incision calcaneal spur resection, always and right now it's always used two incision in sports medicine, and we modified one incision to do this. So in that province, about my training base in different hospital, we did more than 300 of this case. We also write a book. This year we published. Okay, carpal tunnel syndrome. The AUNS for the release of transverse carpal tunnel ligament and median nerve decompression, and also osteochondroma of the distal femur resection. The big one, but one incision is okay to resection. Okay, I will briefly introduction of the AUSS technique right now. Currently, the AUSS technique has developed rapidly in China and adopted in over 400 hospitals across 29 provinces in China, and with more than 40,000 cases completed to date. And I established the 20 national training base in China and 7 international training base. And we have did a lot of training course for these years, more than 70 sessions. Okay, from the 2025, I designed the offline of the training course and for different countries in Kunming, we have the surgery performed, also the hands-on workshop, also the lecture, and in Xi'an and Hanzhong province, and in Chengdu, Guangyuan city, and also in the Kunming, and also in Zhaotong, and also in Changchun. So today, later I will introduce Professor Zhang Boyin, Professor Qu Yang, also the leaders of the training base in Changchun City, in Jilin Province, and also the Chengdu, Kunming, and Lanzhou. Also, we go to Vietnam, we go to Turkey, have the training course, and Incheon, the Russian, and the Uzbekistan, Kazakhstan, the doctors come here, and Chengdu. And we did a lot of sessions of the training course. Okay, this is paper our team published. So you are interesting, we can communicate each other. I will send the papers to you. Okay, right now we also have a remarkable progress in the international training. Right now, I did right now about 32 countries, more than 300 doctors about these countries have the training course, and 7 countries routinely use the AUSS technique. The Turkey, Vietnam, Thailand, Pakistan, India, Indonesia, and also Russia. So this is book. This is book we write. If you are interested, you can translate in your language. And I write about 3 books, and 2 in Chinese version, 1 in English version. And I also this year I also published another 3 books. Next year another 3 books. For this serial, I will publish we will publish about 8 books of the OS technique and AUNS technique. And I think OS technology here's the philosophy of openness, inclusiveness, freedom, and innovation. So today, I think the my our Brazilian friends, the experts from the Brazil, you can do the uniportal microscope UB. I think after today's exchange and communication, you can to try out the OS technique. And thank you very much, and welcome to China, and welcome to the Spring City Equipment origination of the OS technique. And if you are interested of the OS technique, you can come to China. We have a lot of training base in China. Thank you very much.